Good evening, everyone, dignitaries on the dais, and as Madam Sushma Paul Palia said, the beautiful Walter Bushnell family. All of us are their family. Thanks for this opportunity and thanks for this wonderful topic, recurrent pregnancy loss, current concepts. Yes, equally or more frustrating than POI. Definition, we know two or more pregnancy loss, but the biochemical pregnancy, ectopic and molars are not considered. And ASHRAE guideline and American both now say that loss of two or more pregnancies affecting up to 15% of pregnancies and 1 to 2 couples, which is significant clinical challenge. Key risk factors, maternal age, even advanced paternal age, and with each miscarriage, the risk increases and the couples should receive tailored help. If we look at the causes, the most frustrating is 40 to 50% unexplained. Then comes the autoimmune, 20%, endocrine, followed by anatomic, genetic, and infections. Maternal age, yes, significant increase after the age of 35 due to the low oocyte quality and more aneuploid oocytes. And by the age of 40, you can see that 50% risk is there. Uterine factors 7 to 28%, septate, bicornuate, arcuate, and submucosal fibroids, polyps, 2D, 3D, even hysteroscopy and MRI. Genetic factors in the early pregnancy loss could be as high as 50 to 60% with trisomy, monosomy, polyploidy. And also sperm DNA fragmentation is now considered one of the reasons. Hormonal, we know hypohyperthyroidism, hyperprolactinemia, but polycystic question mark luteal phase may be. Diabetes type 1 is also a contributing factor, and low AMH is also now considered when you cannot find any other cause. Severe infections, yes, and bacterial vaginosis for the late loss. Chronic endometritis increases RPL and microbiome imbalance has a possible risk. Thrombophilia, though not common in this part of the world, more in the Western world, but yes, congenital factor V prothrombin mutation, MTHFR, but antiphospholipid syndrome, APS, is one treatable cause. Vitamin D deficiency and insufficiency affects, and immune factors because pregnancy requires maternal immune tolerance. HLA gene variations, we know the autoimmune disease, SLA, APS, thyroid antibodies have an increased risk, and Treg dysfunction, the regulatory dysfunction of the cells, is very important. There is no clear consensus on this. Some guidelines do recommend, some do not. The other lifestyle is smoking, alcohol, psychological stress, environmental and ethnic factors. So it is multifactorial and often unclear. The first thing the patient asks is, what is my chance to prevent this miscarriage and have a healthy baby? So the key predictors are maternal age, number of miscarriages, the type of RPL, early pregnancy loss versus late pregnancy loss, the number of miscarriages, and if she has any previous live birth. Also, the APS antibodies, ANA, and protein S should be considered. We know that after 3 miscarriages, a girl as young as 25 has a risk of 42% miscarriage in the next pregnancy. Treatment, yes, acute is surgical, medical, expectant, but after that, the RPL requires a thorough evaluation and care to identify the cause, the risk factor, and then the treatment, which is challenging. We all know that after 2 RPL, product of conception should be analyzed for chromosomal microarray. If aneuploid, definitely karyotyping and PGTA. If euploid, we consider all other factors. Thyroid replacement and hyperthyroidism should be treated. Progesterone therapy, yes, we have to, there are approved progesterone, dydrogesterone, and 70-alpha hydroxy progesterone caproate, which can be used. The natural progesterone had poor bioavailability, but now with the micronization, the problem has been solved, and the natural micronized progesterone will modulate maternal immune response, suppress fetal immunoplacental inflammatory response, reduce the uterine activity, you improve the uteroplacental circulation. The vaginal is very good because targeted, high concentration due to the first pass effect, minimal side effects, good patient compliance as self-administration. The PROMISE and PRISM trial definitely said that after 3 miscarriages, there is a difference in the live birth rate 72 versus with placebo versus progesterone versus 52 with placebo. And the guidelines, our own Foxy says that vaginal micronized progesterone 400 milligram BD daily till 20 weeks of pregnancy when 3 or more losses. But if I ask here, everybody has prescribed and are still prescribing progesterone because every pregnancy is important. We don't want to wait till it turns to RPL. If there are cramps, we always advise, and that has become a routine, also a fear of litigation. Dihydroprogesterone is a retroprogesterone with high bioavailability, high progesterone receptor affinity, and agonist activity, safe in 20-30 milligram dosage, and it is a selective oral progesterone receptor, effective at much lower doses than oral micronized, and the main metabolite has the same activity. Immunomodulatory action of dihydrogesterone through direct indirect actions will reduce the pro-inflammatory cytokines, increase the anti-inflammatory cytokines, improve the subendometrial blood flow, and successful pregnancy. As early as 2015, a study showed that 10.5 miscarriage rate after this dihydrogesterone administration compared to control, which was 23.5, and 20 milligram can give 92% continuation of pregnancy and 90% patient safety. And the guidelines now, our Foxy says that can be considered in RPL and has been shown to be having the beneficial effect. This is a paper where I've combined vaginal micronized progesterone with oral dihydrogesterone, and it has shown increase in live birth rate and decrease in the miscarriage rate when combination is used. And this publication again has shown that dihydrogesterone may help threatened as well as recurrent pregnancy loss, and all these guidelines have endorsed it. Surgery, I do not believe that septum should not be removed. It can be removed, though guidelines say no proven, but at least fibroids, adhesions, and polyps have to be removed. Vitamin D supplementation we start. Genetic factors should be analyzed. Pre-implantation genetic testing, one of the major indication is recurrent pregnancy loss. A 25-year-old with 2 miscarriages, natural and IVF both, and previous failed treatments, abnormal karyotype of the female, immediately IVF, PGT, SR was done. Out of 6, only 2 normal, 1 transferred, and healthy baby delivered. At our center, we have biopsied more than 3,000 embryos so far from 2014, and RPL has been a major indication. Lymphocyte immunotherapy, it involves the injection either paternal or donor lymphocytes into the maternal body, and it has shown that it can improve live birth rates. But before doing that, because you are sensitizing the mother's body with that foreign antigen which is coming through the sperm, we do the TNF alpha, give TNF alpha if it's high, inhibitory drugs like tacrolimus, or the pentoxifylline. NK cells if it is high, though controversial, intralipids are given. ANA if it's high, definitely HCQS should be given, 400 OD or 200 BD. Anti-TPO steroid should be given. And we do lymphocyte cross-match APCA. If it is not detected, lit therapy is given to promote immunotolerance to the fetal antigen and reduce the rejection and induce the production of blocking antibodies, balance the Treg cells, and cytokine modulation. We start once before she plans a pregnancy. 6 weeks later, she is asked to plan. Once she is pregnant and there is heartbeat, we give the second dose of LIT, and at 12 weeks, the final. After that, it's not needed. A 46-year-old patient, 4 miscarriages, 1 due to round naturally conceived. AMH was good, 0.88. Failed IVF in the US, was advised donor egg. She comes to us. We do laparohysteroscopy, bone marrow-derived stem cells, ovarian instillation, rejuvenation. We also did the EVA, subendo PRP, and along with it, we did the lit therapy. She conceived naturally the next month itself and delivered a healthy baby in US. In IVIG, costly reactions are there, but still they are used empirically. Intralipid, when NK cells high, we can give it, but all under supervision. It will suppress the overactive immune response, reduce the cytotoxic NK cell, promote the immune tolerance, balance the cytokines, and that will help in trophoblast invasion and placental development. Corticosteroids, again controversial, but definitely beneficial in autoimmune unexplained high anti-TPO chronic endometritis. Prednisolone 10 milligram BD or dexamethasone 0.5 BD till 12 weeks of pregnancy. GCSF, still experimental. Thymosin alpha, the new kid on the block for boosting the immunity, because it helps in shift from TH1 to TH2. When the embryo is implanting, it is pro-inflammatory, but immediately after that, the uterine environment should become anti-inflammatory, and it helps in that, but not tried much in the RPL patients. The role of KIR and HLA-C, killer immunoglobulin receptors. So here the female can be AA, AB, BB. AA is the worst. It is the and it can be inhibitory activating type, the inhibitory type. And C1, 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 C2, C2, C2. C2, C2 is the worst. So if the embryo is C2, C2, and here the female is AA, there is a definitely 100% rejection. And here the lid therapy from the partner will also not work. A donor lid should be taken. This is the typical report that we get, and based on that, the treatment is recommended. Chronic endometritis, we do treat it. Mainly it is, though it is said no, but hysteroscopic evidence, and if there is a biopsy, 100% beneficial. Antibiotic therapy, mostly doxycycline, metronidazole group, and steroids are given for a long duration. We are also working on low AMH when all other factors are ruled out, and we go into that 50% unexplained group. There are a number of papers now which say that low AMH can be linked to early pregnancy loss and idiopathic recurrent miscarriage. So this is up to 23. Now we have many more patients, almost about 70, where they had 2 or more miscarriages with low AMH. Age group C34 and 0.44 AMH. So in 13 patients, we did either PRP or bone marrow derived stem cells to rejuvenate the ovaries. We had 4 delivered, 7 miscarriage, and out of that, again 3 got pregnant and delivered. So this patient had 2 miscarriages, naturally conceived. So she went for IVF. Her IVF failed with own eggs. She went for donor eggs. That also failed, and she came to us. We found her AMH was 0.88, and there was no other reason for miscarriage. So we just advised her that we do your ovarian rejuvenation with stem cell therapy. She had come for donor eggs. We convinced her for this, and she conceived naturally and has already delivered. Why should we forget the males? They also have a contributing role in RPL due to the DNA quality, semen quality, genetics, epigenetics, and lifestyle that they have. So now we know that men with RPL can have reduced sperm viability, increased DNA damage compared to fertile controls, and the reduced sperm function. DNA DFI test, that is we do, and DFI HDS test also we do. DFI is linked to infection, chronic illness, diabetes, etc. And HDS is the defective spermatogenesis. If DFI is high and HDS is normal, that is normal spermatogenesis, then consider TISA sperms. This is the typical report. If both are bad, you could do nothing except for the lab procedure and lifestyle changes. But if the DFI was high and HDS was low, then testicular sperms would be very helpful. Psychological impact. While I was sitting here, I got a message, a sanitary pad with a drop of blood on it, a picture that doctor, I have spotting today, what will happen? She is pregnant. This is the anxiety and apprehension of a RPL patient. They are every day, every minute, they are living with that fear that what will happen the next moment. So that strongly psychological support should be given, and more meditation, mindfulness program should be done. Let us look at the guidelines. Bromocriptine, yes, should be given. Vitamin D supplementation given. Multivitamin supplementations to be given, lymphocyte therapy not to be offered. And if we look, they have recommended parental karyotype, uterine cavity assessment, thyroid function, glucose, antiphospholipid antibody testing. Rest is all not recommended as of now. And the pictorial summary, typically the green, and APA, where we give baby aspirin, 75, 88, or 150 with low molecular weight heparin, which could be 0.2 every day, 0.4 thrice a week, or 0.6 twice a week, depending on the patient profile. Thyroid supplementation, uterine anomalies to be corrected but not evidence for septum, genetic tests with genetic counselor and PGTA, immunological tests, no specific treatment, sperm DNA fragmentation, only lifestyle changes, and screen for thrombophilia, which we rarely do here. But there is a red signal for other immunological tests, metabolic or hormonal tests. Definitely lifestyle advice, tender loving care, and prophylactic vitamin D is given. RCOG guidelines says psychological care will cure 75% of your patient. Prognosis less favorable with older and higher. And tender loving care should be given, and mental health should be taken care of. Endometrial sketch not suggested for women with RPL. Again, the same aspirin, low molecular weight heparin, PGTA only in selected cases, other things are not recommended. But to conclude, I'll say that this RPL is a very traumatic condition affecting physical and psychological health. The guidelines vary, but we have to help our patient in whichever way we can. Major factors are genetic, uterine, endocrine, autoimmune. Each patient should have a tailored therapy. Evidence for many of the therapies like IVIG, corticosteroids remains unclear. The challenging part is 50%, 75% couples have unexplained causes. Here, a supportive care, a prognostic tool. I think we should all develop our own prognostic tool by the success that we have based on the miscarriages, age, what is the patient profile, and offer and guidance and support to the patient accordingly. Finally, it all boils down to counseling, tender loving care, and psychological care for the patient and for the couple. For you, it may be one of the number of patients that you see RPL, but for that patient, she is the patient undergoing RPL. So whatever best we can offer, even when we are offering an experimental treatment, we have to tell the patient, this is experimental, maybe this can help, maybe this cannot help, and counsel regarding the side effects, if any, and the cost, and then only offer the treatment to the patient. Thank you so much.
Thank you very much. Please sit down. Nayana Patel, for your excellent, we know because she's been having a lot of experience in this recurrent pregnancy loss and many other field also. I think the experiments, what you showed just now, probably you'll need a whole day to explain to us. Well, I had a very interesting patient. He had 6 abortions, all from Europe, and they were saying there's no other reason at all to abort, but she aborted. But she was aborting by 35 days. All the time, 35 days she had a bleed and she lost it. I just thought out of the box. I said, she's a fertile woman. Why can't you all come to India? Let me just do the ovulation studies and tell you when to have intercourse. And then on day 21, 7 days after ovulation, I did the beta HCG. It was around 15, 20, that way, very low. I started heparin at that time, and the pregnancy continued, and she's got a baby now. This is out of the box thinking. No literature says that. Thank you so much once again.
Thank you, Nana. That was a really wonderful presentation. And I know a lot of algorithms and a lot of things which are going on. But what I really feel is that a thorough evaluation is something which is really, really required. And most of all of us don't focus on lifestyle modification, especially for the couple, both men and women together, because there are a lot of these factors which today are playing their role, and we most of the times over medicalize these pregnancies. And I feel that there are two important things which are very, very important. Support the pregnancy well with progesterone once it happens, but please evaluate and do the lifestyle modification in the preconception period, which is one of the crux now, which is not really focused on, and all of us don't concentrate on that. So I would really bat for that today. Thank you.
Thank, thank you, Naina, for covering such a massive topic in a short period of time. I think RPL is one of the most complex subjects a gynecologist is faced with. And you can see the multiple etiologies. And unfortunately, the guidelines say that almost no treatment is recommended. And it was really like sort of shocking and upsetting for us when the guidelines came out which said that do not remove septum, do not treat submucous myomas, do nothing, which almost all of us actually do not agree to in our practice. Similarly, things change. Like now, the latest ESHRE guidelines have come out recommending dydrogesterone. All these years, there was no role for progesterone. And now, 2025 December guidelines of ESHRE say, especially for luteal support and early days, dydrogesterone is recommended with some precaution, but it is. So things change all the time, and I think all of us, so many years into practice, have our own sort of ways of tackling these patients. Immunological methods, again, Very, very controversial, absolutely not recommended by guidelines. But as you saw, each one has a few cases they can quote where some immune therapy has helped. So I think this is one area where we have a long, long way to go before we really understand and know how to treat. Thank you, Nayana, for throwing some light on this difficult subject.
At the onset, I would like to thank the Berlia family and Walter Bushnell for consistently having such high quality talks and speakers. And thank you, Dr. Naina, for once again giving a great exposition on RPL. I'm very glad that you brought out paternal causes because that has been my theme for my year in ISAR as paternal aging and how we need to treat that 130 kg man sitting next to this woman because I think lifestyle means for both, as Dr. Jaideep very lightly said. I think pregnancy is love and war. So some amount of pro-inflammatory is necessary for the implantation. So I don't completely endorse to trying to suppress the immune system of the woman because I think we need to think about what happens to her maybe 10, 20 years later when we have tried to play with the immune system. We all, in our quest of trying to get a pregnancy, we have to think of the mother and child and think of the long term effects. And I completely believe that tender loving care should be one of the many arms that we look at this woman. And I'm sure JB has worked in RPL in UK, where repeated sonographies, just doing repeated sonographies as reassurance played a major role in trying to get successful pregnancies. So thank you once again, Naina, for bringing out fine nuances. But I think we as doctors have to take one step back before we implement the latest trying to improve our success rates. Thank you.
At the outset, I would like to thank the Berlia family for and the Walter Bushnell team for inviting me here to be a part of this wonderful yearly program, which really brings out the best in academics. And with respect to recurrent pregnancy loss, I think one of the newer things that is emerging is the immunological factor. And we all know the immunological role, the immunomodulatory role of progesterone. And add to that, now the newer things are coming up, like the use of course, there is low molecular weight heparin, the use of intralipids, and now recently even thymosin alpha is being added to the armamentarium. So yes, as Dr. Amit said, we should not jump into it, but we need to investigate patient because each patient is different. Now there are tests which are available to look at the peripheral blood NK cell levels, as well as many other tests which can really indicate whether there is a immunological factor, and if so, then and then only we should be going ahead with these treatments. As of now, they are yet, let us say, in an experimental stage, but as all the panelists have said, in our eagerness to bring out a positive pregnancy, we try different things, and as long as it does not do harm, it is okay. That should be the first principle, and ultimately, I think, as everyone said, the tender loving care seems to be the best thing. Reassurance, reassurance, and reassurance. Thank you.
Good evening, everyone. Thank you, Nana Madam, for excellent presentation. Thank you, Walter Krishna people, for inviting me here. Since I have been long using micronized dydrogesterone, especially nowadays, for all of my recurrent pregnancy loss patients for excellent results. I strongly recommend that while choosing the brand, one should especially so kindly go for the quality product, which is result oriented and already very good nowadays. Thank you.